Assalamu alaikum. So today, how about we dig into this important topic together and see where it takes. And our topic is asthma. Okay, asthma, we know that asthma is a chronic disorder of the airways characterized by reversible airflow obstruction with bronchial hyperresponsiveness and underlying inflammation. Okay, how can we evaluate asthma? For evaluation of the asthma, intermittent respiratory syndrome symptoms like cough, like dyspnea, like wheezing, like chest tightness. If we find these symptoms, then we can do spirometry. In spirometry, if it is obstructive pattern, that means FEV1 by FVC ratio less than 70, then we can give inhaled bronchodilator like SABA, like salbutamol, we can give SABA. If it is reversible, asthma confirmed. If it is not reversible, it's COPD. And if spirometry is normal, even spirometry is normal, you are suspecting asthma, then you should give a drug which can bronchoconstrict, that is methacholine. Methacholine bronchoprovocation test. If it is positive, asthma possible. If it is negative, asthma unlikely. Seek alternate diagnostic like congestive heart failure, pulmonary hypertension, and VCD, like vocal cord dysfunction. VCD, vocal cord dysfunction. Okay, so this flowchart is a very must know flowchart for diagnosis for diagnosing asthma. So again, spirometry. If spirometry show obstructive pattern, think about asthma. In obstructive pattern, there is asthma along with COPD, and if inhale bronchodilator like SABA, is given and the condition is reversing, if it is reversible, that is asthma confirmed. It is not reversible, it is COPD. And if it is normal but you are thinking about asthma, then you should give methacholine. Confirms if methacholine causes bronchoconstriction, then it is asthma possible. And if it is not, and that is asthma unlikely, seek alternate diagnosis: congestive heart failure, pulmonary hypertension, and vocal cord dysfunction. The diagnosis of the asthma can be made in patient with normal or increased DLCO and 12% increase in FEV1 and 12% increase in FEV1 following bronchodilator administration. After bronchodilator administration, if FEV1 is increased more than 12%, if FEV1 is increased more than 12%, then we should think about asthma. Patient with COPD typically had decreased DLCO and less than 12% increase in FEV1 after bronchodilator administration. This is very high thing we should remember. What is the likely diagnosis in an inmate who work who smokes? Inmates who smokes presents rapidly worsening shortness of breath, tachycardia, tachypnea. OSAT is 87%. He is poorly adherent to the asthma medication and began taking ibuprofen for shoulder pain. Uh, The previous night, arterial rash is seen over the trunk and the extremity. Okay, it's anaphylaxis and it can cause laryngeal edema. Anaphylaxis may be confused with an asthma exacerbation if skin involvement is minimal or missed by the clinician. NSI can worsen anaphylaxis. This is the flow volume loop curve. This is the flow volume loop curve where this is the flow volume loop curve where we can see the pattern of obstructive lung disease. This is the pattern of obstructive lung disease, scooped pattern, scooped out pattern. Scooped out pattern, residual volume is higher. Look at the residual volume is higher. In here residual volume is higher and scooped out pattern in asthma. This is the upper air, a fixed upper air obstruction, that is laryngeal edema, characterized by flattening of the top of the bottom of the curve due to limited airflow during both inspiration and expiration. Now, mechanisms by which GERD exacerbate asthma. Very high yield thing that GERD can exacerbate asthma. How? It increased vagal tone, heightened bronchial activity, increased vagal tone, heightened bronchial activity, micro aspiration of the gastric content into the upper airway. Micro aspiration of the gastric content into the upper airway. Patient with asthma has several clues in the history. Patient with asthma has several clues in the history suggesting of comorbid GERD, sore throat, morning hoarseness, worsening cough only at night, an increased need for the albuterol inhaler following meals, an increased need of albuterol inhaler following meals. So patient with asthma has, like, these are the clue in the history suggesting of comorbid GERD, like sore throat, morning hoarseness, worsening cough at night, and increased need for albuterol inhaler following meal. PPI therapy has been shown to improve both asthma symptoms. PPI therapy has been shown to improve asthma symptom and peak expiratory flow rate peak expiratory flow rate in asthma patient with evidence of comorbid GERD. Okay, now status asthmaticus. It's a life-threatening condition and a medical emergency. Features of respiratory failure in acute asthma. Features of respiratory failures in acute asthma, there may be absent or minimal wheezing, poor air movement, silent chest, accessory muscle use, and altered mental status. Accessory muscle use and altered mental status. In ABG shows poor ventilation. ABG shows poor ventilation. PaCO2 is higher. PaCO2 is higher. pH is low. Poor oxygenation, decreased PaO2. Increased lactate, transient increase due to muscle work of breathing, type 1A, and beta agonist induced, type B. Potassium, transient decrease due to beta agonist and or respiratory alkalosis. Potassium transient decrease due to beta agonist or respiratory alkalosis. Management is nebulized albuterol and ipratropium, nebulized albuterol and ipratropium, IV corticosteroid and IV magnesium. Nebulized albuterol and ipratropium, IP corticosteroid with or without IV magnesium. Slow trial, less than 2 hours of NIPPV, non-invasive positive pressure ventilation, and low threshold for intubation and invasive mechanical ventilation. Low threshold for invasive ventilation, low threshold for intubation and invasive mechanical ventilation. Additional bronchodilation with one-time infusion like IV magnesium sulfate may be added if no improvement appreciated after an hour. So IV magnesium sulfate can be added if there is no improvement. So for status asthmaticus, nebulized albuterol, ipratropium bromide, IV corticosteroid, IV magnesium. Short trial, less than 2 hours of non-invasive positive pressure ventilation, and low threshold for intubation and invasive mechanical ventilation. Now, management of the asthma exacerbation during pregnancy. Management of asthma exacerbation during pregnancy. Supplemental oxygen maintains SaO2 more than 95%. Supplemental oxygen maintains SaO2 more than 95%. Bronchodilator, nebulized inhaled albuterol and ipratropium bromide. Systemic corticosteroid if no response to bronchodilator. Oral preferred prednisolone can be given. Magnesium sulfate or tributylin if severe. Epinephrine is contraindicated and intubate for respiratory failure. So look, diagnosis is very important because laryngeal edema laryngeal edema can cause dyspnea, hoarseness, and asthma also cause this dyspnea, hoarseness. So if you are unable to diagnose, is it laryngeal edema or is it asthma, then you will miss, because the drug of choice for laryngeal edema is epinephrine, but in asthma, epinephrine is contraindicated and intubate for respiratory failure. Now, fatal asthma or risk factor, patient history, prior respiratory failure, non-invasive positive pressure ventilation, intubation and ICU administration. Non-invasive positive pressure ventilation, intubation and ICU administration. Poor asthma control, that is inhaler use, frequent oral corticosteroid or acute care visits. Clinical status is respiratory rate more than 30, SO2 is less than 90, excessively muscle use, altered mental status, silent chest. So this is fatal asthma. If respiratory rate is more than 30, SaO2 is less than 90, accessory muscle is using, altered mental status, silent chest. ABG is increased ABG or inappropriately normal PaCO2 relative to work of breathing. Peak flow less than 50% of the baseline. Peak flow less than 50% of the baseline. Okay, what is the next step in the management for a patient with severe asthma exacerbation with elevated PaCO2? Severe asthma, PaCO2 is elevated, endotracheal intubation should be done. Patients with asthma exacerbation. Patients with asthma exacerbation often uh, had tachypnea, which should be which should lead to low CO2, and a normal or elevated PaCO2. Low CO2, normal or elevated PaCO2, impended respiratory failure, inability to meet increased respiratory demand, systemic glucocorticoid, oral prednisolone, dexamethasone, reduced late phase inflammation in the asthma status asthmaticus. So late phase inflammation is reduced by the systemic glucocorticoid, and asthma exacerbation with elevated PuCO2 give do endotracheal intubation. Okay, now because the anti-inflammatory activity of the glucocorticoid because anti-inflammatory activity of the glucocorticoid is delayed by several hours due to the time required to change in nuclear gene expression. They are often given with bronchodilator in the emergency department, beta agonist, and with or without anticholinergic. Corticosteroid are continued at home, like prednisolone 40 to 60 milligram daily for 5 to 7 days to prevent relapse and decrease the need for hospitalization. Now, occupational asthma, workplace antigen inflammation like IgE dependent or independent may cause bronchoconstriction. Classic antigen animal protein, animal worker, seafood, processor, grain, carbohydrate, isocyanates, painter, metals, welder, latency months or years due to gradual sensitization. Initially, symptoms clearly exacerbated at workplace and relieved at home. Over time, symptoms persist throughout week and subside only after sustained work absence. Diagnosis confirm asthma and bronchial hyperresponsiveness, methacholine bronchoprovocation, which confirms the diagnosis. Workplace specific worsening of obstruction like serial peak expirator flow rate at home and at work. By this way, you can differentiate that it is occupational asthma or not. And management antigen avoidance, reduction, respirator, shift rotation, bronchodilator and inhaled corticosteroid desensitization, immunotherapy should be given. Now, diagnosis requires detailed occupational history, careful symptoms, and two-step confirming. First, asthma must be confirmed, reversible obstruction on spirometry. For patient with normal baseline spirometry bronchoprovocation like the previous chart. Next, occupational relationship established, confirming workplace specific worsening of airway obstruction, workplace specific worsening of airflow obstruction. This can be accomplished with serial peak expiratory flow rate, serial peak expiratory flow rate measurement using portable peak flow meter. Patients record their peak expiratory flow rate at home and at work along with their symptoms. A peak expiratory flow rate decline more than a peak expiratory flow rate decline by more than 20% at workplace relative at home is consistent with occupational asthma. Now, exercise-induced bronchoconstriction. Exercise-induced bronchoconstriction, it can cause hyperventilation, incomplete heating and humidification of inspired air, cooler, dry air trigger, and mast cell degranulation. Bronchospasm can occur isolation or in underlying asthma. Clinical feature decrease exercise tolerance. Asthma symptoms appear within 5 to 10 minutes. Asthma symptoms appear within 5 to 10 minutes and improve after more than 20 minutes of the exercise. So asthma symptoms appear within 5 to 10 minutes and improve after 20 minutes of exercise. Diagnosis is supportive empiric response to pre-exercise empiric response to pre-exercise bronchodilator, and confirmation by bronchoprovocation test spirometry before and after the exercise showing more than 50% decline in FEV1. Bronchoprovocation test. This is one form of bronchoprovocation like spirometry before and spirometry after. If it is more than 15% decrease, this is exercise induced bronchoconstriction. Improve control of underlying asthma, step up therapy, pre-medicated before exercise, inhale corticosteroid formoterol 10 minutes before, preferred over SABA, LRTA, ligand receptor antagonist 2 hour prior. So inhale corticosteroid is preferred over SABA and LRTA 2 hour after prior the exercise. Daily inhale corticosteroid beta agonist or LRTA like leukotriene receptor antagonist may be needed for frequent and prolonged exercise. Okay. What is the first line treatment for exercising bronchoconstriction who exercise daily? Inhale corticosteroid and anti-leukotriene agent 10 to 20 minutes before exercise, and use beta agonist if only needed a few times per week. Okay, now treatment for non-controller medications. Okay, now step up strategy for asthma management. Step 1 and 2. Look at step and 2. Inhale corticosteroid formoterol. Inhale corticosteroid formoterol may be used as PRN. And step 3. Inhale corticosteroid and formoterol daily. Inhale corticosteroid and formoterol daily. Low dose inhale corticosteroid. Step 3. It is used step 1 and 2. It is used less than daily. Step 3. It is most days waking with asthma. And step 4. Inhale corticosteroid formoterol daily medium to high dose inhale corticosteroid daily symptoms waking with asthma decrease FEV1. And step 5. Inhaled formoterol daily high dose inhale corticosteroid and LAMA. Consider biologic therapy anti-IgE or anti-IL-5 or 5R monoclonal antibody still uncontrolled after step 4 and frequent need for oral corticosteroid. Okay, you need to remember this. Now look at this box. If intermittent symptom less than 2 days per week, if intermittent symptoms less than 2 days per week. Okay, for intermittent symptoms, intermittent like less than 2 days a week and nighttime awakens less than 2 times a month. Indication is step 1 therapy, mild persistent. Mild persistent means like symptoms frequency more than 2 days a week but not daily, 3 to 4 times a month, nighttime awakening. This is step 2. For moderate persistent, daily. For moderate persistent, daily symptoms and nighttime awakening 1 time a week but not nightly, step 3. And severe persistent throughout the day 4 to 7 times a week and step 4 or 5 is our choice. Okay, look at the adverse effect of inhaled corticosteroid. Local is dysphonia. It is due to steroid-induced laryngeal myopathy. Steroid-induced laryngeal myopathy. Common 50% usually minor. Oral thrush can happen, so prevent by rinsing or gargling with water and using spacer. And other like contact dermatitis, budesonide, hypersensitivity, and cough and reflex bronchoconstriction may happen. And systemic like HPA-axis secondary adrenal insufficiency and can coexist with inhaled corticosteroid induced Cushing syndrome, skeletal like small increase osteoporosis and fracture risk, and other like dermal thickening and cataract formation can happen. Okay, young, you cannot give a LABA without inhaled corticosteroid or steroid. This will increase mortality and is always the wrong answer. If the patient is on only LABA, they must be on steroid. Never use LABA first or alone. Okay, the patient, if somebody has leukocytosis with neutrophilic predominance, leukocytosis with neutrophilic predominance in a patient being treated with asthma exacerbation, glucocorticoid side effect. This is the glucocorticoid side effect. The primary long-term intervention for persistent asthma, is daily inhaled corticosteroid versus long-acting anticholinergic inhaler. Okay, so that's all about asthma. It's a long talk, but it's a very real topic. In the next session, we will discuss some questions regarding asthma and COPD. Hope you enjoy.